चलो बच्चों, hopefully I'm audible and the screen is visible as well, and we can start. Oh, great. So now let's start without any further delay. Okay, and I hope all of you were able to follow. Okay, we were discussing about intestinal obstruction. I've told you there are classical symptoms of intestinal obstruction. The patient presents to us an emergency with colic abdominal pain, abdominal distension, vomiting, constipation, and obstipation. There are two types of intestinal obstruction, either dynamic or adynamic. Dynamic one is due to physical obstruction, whereas adynamic one, there is no physical obstruction, but just the intestines have lost their motility. There is no peristalsis. Important is definitely for initial investigation for intestinal obstruction, we go for an X-ray abdomen. Both the views are taken, erect as well as the supine view. Erect view will tell us whether the patient has an obstruction or not, and if the patient has an obstruction, on the erect view of the X-ray abdomen, will be able to see multiple air fluid levels. If it is the supine view, it will tell us what is the exact site of obstruction. If the small bowel is obstructed, definitely the distended bowel loops which are there, they will be seen in the center. Whereas if the large bowel is obstructed, definitely larger loops will be seen, distended bowel loops in the periphery. Important is, if it is a small bowel obstruction, we have to consider whether it is a jejunal or a ileal obstruction. If it is a jejunum obstruction, we know that jejunal mein definitely there are mucosal folds known as the valvulae coniventus, also called as the plicae circularis. Due to presence of that, we'll be able to see the classical step ladder pattern if it is an obstruction in the jejunum. But the ileal loops which are there, bache, they are distended, but they do not have any special feature. They are featureless or they are characterless. Okay? So that's the important thing. Investigation of choice to confirm our diagnosis further. In an adult, it is always a CECT abdomen, that is a contrast enhanced CT scan of abdomen, whereas in a child, it is always an ultrasound abdomen. Okay? If I talk about the treatment of the patient, so in the treatment, you have to remember one thing, that in this person, okay, सबसे पहले, the first line management for this person when this person is admitted in the emergency is always and always a conservative management. अब से याद रखना है, जब भी मैं conservative management बोलूँ and in surgery बोलूँ, तो there are four things that you have to consider. First, when a patient gets admitted in a surgical ward or a surgical emergency, and we say conservative management, we mean four things. What are those four things? First, the patient has to be kept NPO, nil per oral. उसको orally कुछ नहीं देना है because the intestines are obstructed. Second, definitely I have to give IV antibiotics to the patient because there will be a higher risk of infection. So to avoid that. Third, we have to give analgesics to the patient. Analgesics bache are not anything but painkillers because the patient will be having pain. That is the reason definitely we have to give painkillers to the patient. And last one definitely will be IV fluids because we are not giving anything orally, but the patient wants nutrition, right? So that is the reason why we have to give IV fluids to the patient. These are the four things. Whenever I say conservative management, these four things should come to your mind. Okay? So if I talk about the management in a patient of intestinal obstruction, the first line management over here will be a conservative management. And if I talk about a conservative management, it is nothing, keep the patient NPO, nil per oral, give IV fluids to the patient as we are keeping the patient NPO, give IV antibiotics to the patient, and also give analgesics to the patient, that is nothing but painkillers should be given. Okay? So that is the important thing, conservative management ke liye. Now once we are doing conservative management in the patient, bacho, we have to keep on monitoring this patient. We have to keep on monitoring this patient for improvement. Okay, we have to keep on monitoring this patient for improvement definitely, bache. Okay, we have to see whether the patient is improving or not. Okay, whether the patient is improving or not. So if the patient's condition improves, then koi dikkat hai kya? No, nothing. Okay, so if the patient's condition improves, then just discharge the patient. Yeah, if the patient's condition improves, that means the intestinal obstruction has been relieved and you can just discharge the patient. But if the patient's condition worsens, rather you have to remember that if the patient's condition will worsen, अगर patient की condition क्या हो जाती है? Worsen हो जाती है. In that condition, you have to take up the patient for a surgery. And which is the surgery? We give a large incision starting from here till here. Okay? A large incision is given and we open the abdomen for the patient. Why? Because if the patient's condition has worsened, that is suggestive that the patient might have had what? The patient might have had a perforation or a strangulation. Okay, so अगर patient की condition worsen हो जाती है, that is hint that the patient might have had a perforation due to which the patient might develop a peritonitis as well. क्योंकि अगर perforation हो गया तो definitely all the contents of the intestine will go into the peritoneum and it will cause inflammation of the peritoneum, that is peritonitis. Got it? So perforation, peritonitis can occur, or the second risk can be strangulation. Second risk क्या हो सकती है? Strangulation. That means there is almost no blood supply to the intestine, that can cause necrosis of the intestine. So both of them will be the risks. That is the reason when the patient's condition is going to worsen, we have to take up the patient for a surgery, and that surgery is opening up the abdomen of this patient and to look for what is the real problem. That is, exploration should be done. So that is nothing but a exploratory laparotomy. It is nothing but a exploratory laparotomy which is done in a patient of intestinal obstruction. ठीक है, but majority of the patients which are there of intestinal obstruction, they do improve on conservative management itself. ठीक है, they do improve on conservative management. ठीक है, कोई दिक्कत नहीं है इसमें. Hopefully I am made myself clear. Right, now next important is when there will be a risk of rupture. I don't have space over here. The risk of rupture, now by that I mean कि what is the critical diameter, after what diameter of the intestines will dilate further or distend further, they are going to rupture. ठीक है, so that critical diameter has been asked in your examination बच्चे, so please be aware of that. So here I am writing the risk of rupture बच्चों, the risk of rupture is seen usually. Okay, so you have to remember it as small intestine, large intestine and the cecum. That means the risk of rupture will be seen in a small intestine if it is more than 3 centimeters dilated. If the small intestinal loop is more than 3 centimeters dilated, it is going to rupture. That is the critical diameter. Second, if the large intestinal loop or the colonic loop is more than 6 centimeters dilated. If the large intestinal or the colonic loop is more than 6 centimeters dilated, it is going to rupture. And finally, the cecum. Cecum if it is more than 9 centimeters dilated. Cecum is a part of large intestine or the colon itself, but important is the cecum which is there, bache, already it is a large part. So therefore, if the cecum is more than 9 centimeters dilated, then it is going to rupture. So 3 ka table hai, 3, 6, 9. Okay. So that you have to remember, small intestine more than 3 centimeter, large intestine more than 6 centimeter, and cecum more than 9 centimeter. And this has been a question. Okay, this has been a question. कोई दिक्कत नहीं है इसमें, that has to be remembered. Now if I talk about the types and their causes, okay, we have already, this was about the overall management of the patient, right? Now let's talk about the specific types. If I talk about the dynamic intestinal obstruction, you have to remember that the most common cause of dynamic intestinal obstruction is nothing else but adhesions. Yeah, the most common cause of dynamic intestinal obstruction is nothing else but adhesions usually. What are adhesions? मैंने वही बोला, adhesions nothing मतलब चिपक जाता है, ठीक है, intestine के दोनों walls एक दूसरे से चिपक जाती है बच्चे, definitely that is what is an adhesions. Okay, so usually adhesions or synecdoche which are there, they're nothing but the intestinal walls will get stick to each other. That is what is adhesions usually. There are multiple causes of adhesion. There can be a lot of causes of adhesions. What are those? Let's enumerate some few causes of it. Please remember, adhesions usually, they can be due to infections, something like a tuberculosis. Okay, they can be due to infections, something like TB, or they can be due to infection. They can be due to condition like, for example, Crohn's disease. Crohn's disease, we know it is an inflammatory bowel disease. It is causing inflammation of the intestine, and as it causes inflammation of the intestine, definitely during inflammation walls are going to be sticky, and during the repair maybe or during the healing process, there can be adhesions which will be formed. So TB ho gaya, second will be Crohn's disease. Okay, second will be Crohn's disease. Apart from that, definitely, usually after a surgery also, a lot of surgeries, when you have operated the bowel now, when you have operated the bowel, there is a very high risk after the surgery. When you have applied sutures, there will be a risk of adhesions usually. Okay, so usually after a lot of surgeries, there will be a risk of adhesions as well that will be formed in the patient. Okay, so in a lot of other infections also, you have to remember, or even in malignancies, there can be a lot of adhesions which can be formed. So infections, malignancies, TB, Crohn's, surgeries, multiple other conditions which can lead to a lot of adhesions in the intestine. Now important is, what is the management of the patient? As I've told you, initial management will always be conservative management, and if on conservative management only the patient improves, that means definitely the adhesions were temporary and now the adhesions have been relieved and patient को घर छोड़ा जा सकता है. Okay, we will confirm it with definitely X-ray and a CT scan. If that shows no adhesions, then definitely we can leave the patient home. But if the adhesions are still present, bache, then we have to go for a adhesiolysis. What is adhesiolysis? We will go inside via an endoscopy or a colonoscopy, and then we are going to break these adhesions. Okay, that management will be called as adhesiolysis. If the patient's condition does not improve, we have to go for an adhesiolysis. Okay, but conservative management पे अगर improve होती है, leave the patient. ठीक है, if it does not improve, go for an adhesiolysis. Next important is the second most common cause of dynamic intestinal obstruction after adhesions is nothing else but the stricture. Now, what is the stricture? So, for example, these are your intestinal walls. Now, these intestinal walls have become inflamed. पहले ये inflamed हो गई है. उसके बाद क्या हो जाएगा इनका? During healing, they will undergo fibrosis. During healing, they will undergo fibrosis. Can you see? As they are undergoing fibrosis, definitely they are causing intestinal obstruction. Yes, and this fibrotic part of the intestine is what is called as a stricture. Okay, so that is important. You have to remember, बच्चे, stricture is nothing but fibrosis which is caused due to healing. Okay, so अगर stricture होता है patient में, that can also lead to a dynamic intestinal obstruction. The patient is going to have complaints like the causes of the stricture is going to be like, there will be multiple causes of stricture in the patient. Some of the causes can be infections like PID, that is pelvic inflammatory disease. Yes, when the pelvic inflammatory disease spreads to the abdominal cavity and it is going to cause inflammation of the intestine, that can lead to fibrosis in the intestine, leading to formation of strictures. Next important, definitely endometriosis. The same logic applies. Endometriosis spreads to the abdominal cavity and there will be risk of fibrosis at the end. Okay, same with radiotherapies. Radiotherapy is known to cause fibrosis as well. TB, definitely TB is an infection, or any kind of other infections can cause this. Whereas Crohn's disease, definitely Crohn's disease is an inflammatory condition. Because there is inflammation in the intestine, that inflammation is going to heal, and that healing will occur with the help of fibrosis. So that is going to cause a stricture in the patient. Now important is, if there is a stricture, definitely again first line will be conservative management, improves discharge. Does not improve, then in that condition usually you have to go for what? In this condition, we have to go for management of the stricture. Now, if it is a very small part, if it is a very small part which is having a stricture, for example, something like this, okay, can we just cut this part? Can we just cut this part and join the remaining parts? Yes. So I can cut this part and join the remaining parts. That is called as, cutting is known as resection, joining is called as anastomosis. So I can go for a resection and anastomosis. Yes, but if it is a very large part which is having the stricture, it is a very large part which is having a stricture, or there are multiple strictures throughout the intestine, then we cannot go for a resection and anastomosis. इतना बड़ा part काटना या बहुत सारे parts काटना is not feasible. In that condition, what we have to do? We have to repair the stricture. Okay, we have to actually repair the stricture itself. Okay, that is called as stricturoplasty. Okay, that will be called as stricturoplasty. So please remember, here the treatment can be either a resection and anastomosis. If it is a very small part, it can be resection and anastomosis, or if that's not possible, we can even go for a stricturoplasty. Okay, we can even go for a stricturoplasty. No issues with this, anybody? That's the important thing you have to remember. Next important is, if I talk about adynamic intestinal obstruction, if I talk about the adynamic intestinal obstruction now. Adynamic matlab, I have already told you, there is no physical obstruction, but the patient's intestines are not having motility. As they are not having motility, they are not able to perform peristalsis, and therefore the food is not able to move inside the intestine. That is what is an adynamic intestinal obstruction. If I talk about adynamic intestinal obstruction, you have to remember one fact. Here there is failure of the bowel to contract. As the bowel is not able to contract, therefore there is no peristalsis. Okay, and what is the cause of it? It is due to failure of neuromuscular transmission. One of the causes can be due to failure of the neuromuscular transmission, because when the nerves will stimulate the muscle, जब nerves एक signal देते muscle को, then only the muscles will contract, and then definitely there will be a peristalsis which will occur. But यहाँ पे क्या हो रहा है? The nerves are not stimulating the muscle. As the nerves are not stimulating the muscle, muscles are not contracting, and as muscles are not contracting, बच्चे, that is the reason why definitely the patient is not having any kind of peristalsis in the intestine. ठीक है? So there is a failure of neuromuscular transmission. There is a failure of neuromuscular transmission. Therefore, the bowels are not able to contract. ठीक है? What are the causes of this adynamic intestinal obstruction? There can be multiple causes. First of all, it is post-operative. Yes. So post-operatively or after surgery, usually there will be a dynamic intestinal obstruction, because definitely during the surgery all the muscles of your body, they have a decreased tone, their motility is decreased definitely, the contractility is decreased. But after surgery, they usually regain their motility. After surgery, they usually regain their motility. But please remember, sometimes what happens is, even after few days of surgery, the patient's intestine are not able to regain the motility, they are not able to perform the peristalsis. Such type of condition is what is called as a paralytic ileus. Yes, such type of a condition is what is known as paralytic ileus, which is actually the cause of your adynamic intestinal obstruction. When the intestines are not able to perform peristalsis, they are paralyzed because they are not able to contract. That condition is known as paralytic ileus, which is actually the most common cause of adynamic intestinal obstruction. So adynamic intestinal obstruction is actually paralytic ileus, which can be seen due to multiple conditions. One is definitely post-operatively it can be seen because the intestines have not regained their motility, वापस नहीं आई उनकी motility. Second is due to uremia. Uremia is nothing but the patient was having a kidney disease, and due to kidney disease there were excess of urea or ammonia collected in the patient's body. Okay, so uremias can also be one of the important causes. Second is definitely dyselectrolytemia. Now definitely dyselectrolytemia, जो electrolytes की levels होती है blood में बच्चे, वो गड़बड़ हो जाती है. There is a dyselectrolytemia, and this was a question, which is the most common electrolyte abnormality, which is known to cause paralytic ileus or adynamic intestinal obstruction. This was a previous year question. You have to remember it is hypokalemia. ठीक है? So please remember the most common electrolyte abnormality which is there, which is known to cause paralytic ileus, is nothing else but hypokalemia. It is nothing else but hypokalemia. ठीक है? That has been a previous year question. Now here the patient will have any kind of pain or what? No pain. Why? Because there is no obstruction only. The intestines have lost their motility. As there is no physical obstruction and the intestines are not performing peristalsis. In dynamic intestinal obstruction, why the patient was having pain? Because the intestines were vigorously performing peristalsis. यहाँ पे peristalsis नहीं हो रहा. So that is the reason the patient is not going to have any kind of pain. But the other features of intestinal obstruction will be present, like there will be abdominal distension, there will be vomiting, there will be constipation, there will be obstipation. All of these features will be there. Okay, if I talk about the investigation of choice in the patient, investigation of choice in this patient will be what? Again the same one, that is nothing else but CECT abdomen. Okay, investigation of choice in the patient is going to be CECT abdomen. Okay, and now if I talk about the management of this patient, if I talk about the management of this patient, what will happen, what should be done with this patient? So here we just have to treat the underlying cause. Whatever is the underlying cause of your adynamic intestinal obstruction, we have to treat that. Once we treat that, definitely the intestines are going to regain their motility. वापस से उनकी motility मिल जाएगी, वापस they will start their peristalsis and the intestinal obstruction will be relieved. अपने आप चला जाएगा वो, ठीक है? So here you have to actually correct. Here we have to correct the electrolyte disturbances. Okay, here we have to correct the electrolyte disturbances in the patient. Here we have to correct the electrolyte disturbances in the patient, okay, or the underlying cause, whatever it is. Okay, important is after surgery, which is the first organ to regain the motility? That has been a previous year question. The first organ in the abdomen which is to regain the motility is the jejunum. The first organ to regain the motility which is the jejunum, and the last organ to regain the motility is the colon, the large intestine. The last organ to regain the motility is the colon, that is your large intestine. No issues with this. The first organ to regain the motility is jejunum. The last one to regain the motility is the colon. Okay? That was about your adynamic intestinal obstruction now. Okay? And this has been a question. Okay? Previous year questions the. So please remember this. Next important, if I talk about the duodenal atresia now. What is atresia? We have discussed yesterday already. Dynamic का management तो बता दिया ना. Dynamic पहले तो conservative जाएगा. Then definitely it will be done by either adhesiolysis if the cause is adhesion, or resection and anastomosis, or structuroplasty if the cause is stricture. Right? Depends on the cause in dynamic. What is the cause actually? Now if I talk about duodenal atresia, बच्चे, atresia we have already discussed. Atresia का मतलब होता है absence or no development. Here the duodenum, some part of the duodenum is not developed properly. Why? Because I hope all of you are quite aware. Some part of the duodenum is developed by the foregut till the second part, and some part of the duodenum is developed by the midgut, okay, or second part or third part onwards. ठीक है? इन दोनों का जो fusion होता है, that leads to formation of the complete duodenum. But sometimes what happens is both the parts are formed, but they are not able to connect with each other. Both the parts are formed, but they are not able to connect with each other. ठीक है? Opening ही नहीं बनती उनके बीच में. That is the cause. Or if both the parts are formed but in between them there is a definitely a presence of fibrotic band. जो बीच का हिस्सा बनना था वहां पे that part has not formed, rather there is a presence of a fibrotic band in between. ठीक है, so these are the usual causes that is there for duodenal atresia. There are various types of duodenal atresia depending on that. ठीक है, if I talk about duodenal atresia बच्चों, you have to remember duodenal atresia is nothing but absence of some part of the duodenum. Okay, it is nothing but absence or no development. It is absence of duodenum. Okay, it is absence of some part of duodenum. You have to remember that. Okay, because of no development. Important is it is a cause of neonatal bowel obstruction. Okay, you have to remember, if a neonate has a bowel obstruction, the most common cause for it is actually duodenal atresia itself. Okay, so the most common cause for a neonatal bowel obstruction is usually duodenal atresia itself. It is duodenal atresia itself. Now, if I talk about the clinical features of the child, of the child, here, what did I tell you? This is a close differential diagnosis between CHPS. Reason is CHPS and duodenal atresia. Why both of them are close differentials? The reason is in both the conditions, the child will be a neonate and they will be presenting with classical features of projectile vomiting. Okay, what is the difference? First, the time of the presentation. Second, the type of the vomiting. Okay, important is here the child will present at birth itself. Yes, because there is duodenal atresia, complete blockage. वहाँ पे तो narrowing थी ना, so at least some milk can pass for some time. But and the patient presents to you after 2 to 3 weeks. Okay, in a CHPS case. But here the child is going to, or the neonate will be presenting to us at birth itself. Okay, and what will be the complaint? Okay, the classical complaint of the child will be what? Severe abdominal distension हो जाएगा, बच्चे का पेट एकदम फूल जाएगा, will be severe abdominal distension in the child along with a classical bilious vomiting. Why there will be a bilious vomiting? Because it is a bile mixed vomiting. So याद रखना, in this case, it depends on the site of obstruction whether the patient or the neonate is going to have bilious or non-bilious vomiting. Sometimes there are chances अगर first ही part बना है, second part बना ही नहीं है, this patient of duodenal atresia can also have a non-bilious vomiting. ठीक है, उसमें तो bile आएगा ही नहीं फिर, but there will be most of the times that the patient is having actually obstruction beyond the second part. That is the reason why here more commonly there is a bilious vomiting itself. That is a bile mixed vomitus is there. So bilious vomiting will be there. Green color vomitus होता है थोड़ा सा. ठीक है, तो bilious vomiting is there in the patient. Along with that there is a severe abdominal distension. Okay, there is a classical abdominal distension which is there severe. ठीक है, that will be present in the child. Important is now, apart from this, you have to remember this duodenal atresia is a congenital anomaly which is associated commonly with trisomy 21. What is trisomy 21? Down syndrome. So you have to remember it is commonly associated with Down syndrome. Yeah, this is a congenital condition which is commonly associated with Down syndrome. Okay. Next important is what is the initial investigation. This has been a previous year question. जो भी underline वाले हैं ना, these have been previous year questions. Please remember that. ठीक है. Duodenal, which among the following gastrointestinal anomaly is commonly associated with Down syndrome? The answer was duodenal atresia, and vice versa also it has been asked. Duodenal atresia is commonly associated with which chromosomal abnormality? Answer is Down syndrome, that is trisomy 21. Now if I talk about the next one, bache, what is the initial investigation? So initial investigation in this child is again going to be X-ray abdomen, and when we do a X-ray abdomen in this child, we are able to see a classical feature. And what is that classical feature? This one. This was a recent exam question in this 30th July examination. But वहाँ पे इतना था, one of the bubble which was there, it was very, very small. So people were confused whether it is a single or a double bubble. But it was a double bubble. A lot of people have confirmed it. So as you can see over here, the first bubble which is there, it is of the stomach. And the second bubble which is there, it is of the part of the duodenum which has been formed. Okay, the part of the duodenum which has been formed. This is the classical double bubble sign. कौन सी sign होती है ये? This is the classical double bubble sign. So double bubble sign is classically seen in a patient of duodenal atresia. But apart from patients of duodenal atresia, will it be seen in other conditions also? Yes, it will be seen in another conditions. What will be those? So you have to remember, apart from a patient of duodenal atresia, बच्चे, it will be seen in another condition known as annular pancreas. अब ये annular pancreas क्या चीज होती है? So you have to remember, annular मतलब ring like. Annular means ring like. So you have to remember, for example, this is the duodenum of the patient. Okay, so around this, definitely we will talk about that in pancreas. There is a ring like pancreatic tissue which is formed, as this ring like pancreatic tissue is formed, bache, therefore it is going to compress the duodenum from outside. Okay, so please remember this pancreatic tissue which is there, it is going to compress the duodenum from outside. It is going to compress the duodenum from outside, and that ring like tissue, as it causes compression of the duodenum from outside, it is going to cause duodenal obstruction, and that can also lead to a double bubble sign therefore. And the third one is Latz band. It is actually a fibrotic band which is formed around the second part of duodenum again. Therefore, that can also lead to a classical double bubble sign. So, double bubble sign iske baad se aaye. So, please remember there are three causes for it. First, duodenal atresia. Second, annular pancreas. And third will be a Latz band. Okay? So, that has to be remembered. Now, if I talk about the investigation of choice in the patient. So, if I talk about the investigation of choice, please do remember here the investigation of choice has to be CECT abdomen. Here the investigation of choice. Usually, as I've told you now, we do not commonly prefer CCT in neonates or in children. We prefer ultrasound abdomen for most of the intestinal obstruction ka cases. But here on ultrasound abdomen, we will not be able to make it out properly. That is the reason why it's better for a CCT abdomen, where the contrast will not be able to travel further from the duodenum, and that is the reason here it can make easily a diagnosis of duodenal atresia. Okay? Next, what is the management in this patient? Now management is what? See, duodenum ke there are two parts of the duodenum which are not connected to each other. What is the best treatment? Just take both of these parts and just try to connect them, just try to join them. That is what is called as anastomosis. So it is duodenal anastomosis, or we can even call it as duodenostomy, right? Because we are connecting both the parts with each other, we are creating a stoma. Therefore, it is duodenostomy. If it is not possible, if you are, for example, second part of the duodenum is very far away. If the second part of the duodenum is very far away, or the second part of duodenum is not properly developed only, then it's better to bring your jejunum over here. Wele dos ko lao tumhare aur usko yahan pe connect kar do. Okay, to bring your jejunum over here and you have to connect it on the side. Okay, so that will be connected over here. That will be called as duodenojejunostomy. Better one is always एक जैसा ऑर्गन एक दूसरे से के साथ कनेक्ट हो. दैट मींस duodenostomy will always be better than a duodenojejunostomy. ठीक है? So please remember both can be done, but the better one is always a duodenostomy. But the better one is always a duodenostomy or a duodenal anastomosis. If that is not possible, in that condition we go for a DJ-stomy. DJ-stomy is nothing but a duodenojejunostomy. ठीक है? So that has to be remembered. Previous question it has been. कोई दिक्कत नहीं है. That was all about your duodenal atresia. That was all about your duodenal atresia that you have to have an idea about. Now important is बच्चे, will there be absence of some part of jejunum or ileum? Yes, there might be, and that condition is called as jejunal atresia or ileal atresia respectively. If I talk about jejunal atresia, please remember among atresias, usually jejunal atresia is the most common type. Yes, but it is not so severe as duodenal atresia. Yeah, among atresias, jejunal atresia is the most common type, and but it is not most severe as if a case of jejunal atresia. And here we are able to see which sign. Here you will be able to see three bubbles. Here you will be able to see the classical three bubbles on the X-ray abdomen. And this is what is called as first bubble is the stomach, second bubble is the duodenum, and the third bubble is the proximal part of the jejunum. Okay? That is what is called as the triple bubble sign. Okay? So jejunal atresia mein the X-ray abdomen classically shows us the triple bubble sign. It classically shows us the triple bubble sign. No issues with this, anybody? That is important to be remembered. It classically shows us the triple bubble sign. If I talk about ileal atresia mein you have to remember. Can you see over here? This is the case of ileal atresia. This is the X-ray which shows ileal atresia. So please remember, in ileal atresia, definitely there will be first bubble of the stomach, second bubble of the duodenum, and then there will be multiple other bubbles which will be there. So this is what is classically known as the multiple bubble sign. This is what is classically called as the multiple bubble sign. So this is what is known as the multiple bubble sign. Okay. So ileal atresia will classically present to you with multiple bubble sign. Okay. It will classically present to you with multiple bubble sign. कोई दिक्कत नहीं है बच्चे. So duodenal atresia is much more important that you have to remember. ठीक है. Next important if I talk about is intestinal TB. If I talk about a case of intestinal TB, you have to remember that intestinal TB is also known as abdominal cox. Why? Because I hope all of you are quite aware that your Mycobacterium tuberculosis, which is there, the causative organism, it is also known as the Koch's bacillus, because it was discovered by Dr. Robert Koch. It is also known as the Koch's bacillus, and that is the reason why intestinal TB can also be referred to as the abdominal cox. Okay. Now important is, as TB is an infection, it is going to cause inflammation in the intestine, and due to inflammation there will be healing as well, and when there is healing there will be fibrosis as well, and due to fibrosis the patient can have intestinal obstruction also. Okay, due to the fibrosis the patient can have intestinal obstruction. Even we know that TB can even cause adhesions, and due to that adhesions also the patient can have obstruction. Okay, that is the reason we are studying intestinal TB in a case of intestinal obstruction. Most common site is which one? Most common site is the one where the small intestine, that is your ileum, is going to end and your large intestine is going to start. This site known as the ileocecal junction, or we can call it as the ileocolic junction. This is the most common site for your intestinal TB. Okay, so the ileocecal junction. Okay, the ileocecal junction or the ileocolic junction is the most common site for your intestinal tuberculosis. For your intestinal tuberculosis. कोई दिक्कत नहीं है इसमें, that has to be remembered. This patient is going to have what? As the patient is going to develop adhesions over here. The patient might develop adhesions over here or strictures over here. The patient will have intestinal obstruction, and due to that the patient will constantly complain of abdominal pain. The patient can complain of abdominal pain constantly, or the patient will also complain of chronic constipation as well. The patient might complain of chronic constipation because it is not a complete intestinal obstruction. There is a partial intestinal obstruction, due to which the patient keeps on having abdominal pain and the patient keeps on having chronic constipation. Apart from that, there will be the classical constitutional symptoms of TB. What are those constitutional symptoms of TB? The patient will have the same low grade fever, which mainly rises during the evening time. That will be the feature. Second, the patient can have drenching night sweats, which will be there. Third important, the patient loss of appetite, that is anorexia. And fourth, due to that reason the patient might have weight loss as well, unintended or unintentional weight loss. All of these features will be seen, which are the classical and constitutional symptoms of tuberculosis in the patient that we have discussed already. Okay. If I talk about investigation, बच्चों, investigation में definitely for intestinal obstruction we always go for an X-ray abdomen, but further we can even go for a barium enema. Okay, we can even go for an barium enema, which is a contrast study, and on that barium enema we'll be able to see a classical feature. क्या दिखता है on the barium enema? You have to remember, on the barium enema this classical feature is seen. What is this? Can you see this is the ileocecal junction, and at this ileocecal junction you can see that the cecum appears pulled up. ये जो cecum है ऐसा लग रहा है इसको ऊपर उठाया किसी ने. Okay, the cecum appears pulled up. It is actually due to the fibrosis at this level. As there is fibrosis at this level now, or the strictures which are there at this level, they are going to give a classical appearance of a pulled up cecum. Second, apart from this, can you see there is narrowing of the ileocecal junction, and this narrowing of this ileocecal junction बच्चे is giving us a classical appearance known as the goose neck deformity. This is known as the classical goose neck deformity as well. Okay, so let's write down. You have to remember important things. On barium enema, the patient is going to have the classical features. One is called as the pulled up cecum. First is called as the pulled up cecum, and the second classical is what is called as the goose neck deformity. The second classical feature is what is known as the goose neck deformity. Okay, that's important. Now definitely if the patient is not having any type of adhesions or any type of strictures over there, the patient is not having intestinal obstruction as such, okay, the patient is only having intestinal TB or abdominal cox, no complications as of now, then you can just start ATT in the patient. Yeah, you can just start ATT, anti-tubercular therapy in the patient. The patient will be treated by a physician then. Okay. But if the patient is having complications, if the patient is having strictures, or if he is having adhesions, and if he develops intestinal obstruction due to that, then definitely it is our responsibility to treat the patient. Okay? So important is, if I talk about the treatment, so usually ATT will be given to the patient. Okay, we are going to give ATT to the patient, bache. Along with that, definitely we have to go for surgery or surgical management whenever it is required, whenever the patient has features of obstruction. Whenever the features of obstruction will be present, we have to go for a surgical management. We have to go for a surgical management. And what is that surgical management? If there is a lot of fibrosis at the ileocecal junction, if there is a lot of fibrosis at the ileocecal junction, we are not able to do a structuroplasty, or we are not able to do adhesiolysis, then we have to go for a resection and anastomosis. Okay? So the same surgical treatment that we have discussed for dynamic intestinal obstruction, because I've told you for dynamic intestinal obstruction, whether it is adhesions or it is structures, in both the conditions, one of the common causes was TB. Okay, so according to that, you have to manage the patient. Okay, next one will be sigmoid volvulus, an important condition now. Volvulus I have already discussed, bache. What is volvulus? Volvulus is nothing but twisting of an organ or malrotation of an organ. Agar organ galat, it is anti-tubercular therapy. Okay, so now if an organ has twisted itself or the organ has undergone a malrotation, definitely. Agar your organ, for example, this is your intestine, and agar iski twisting ho gayi, this is what is called as an valvulus. This is what is called as an volvulus. Okay, so that is important. You have to remember, we have discussed about volvulus in the stomach also, but overall in the GIT, if they ask you which is the most common site for volvulus, it is not the stomach. Overall in the GIT, the most common site for volvulus is going to be your sigmoid colon. Yes. Okay, so let's talk about your sigmoid volvulus now. Sigmoid volvulus which is there, it is nothing but malrotation of the gut or malrotation of the sigmoid colon. Okay, so the most common site, you have to remember, the most common site for volvulus is nothing but the sigmoid colon. The most common site for volvulus in the whole GIT has to be the sigmoid colon. Has to be the sigmoid colon. Please remember this. Okay? That is important to be remembered. Next important is, we have discussed that already there is malrotation or twisting, but in which direction? Okay, it is actually in the anti-clockwise direction. Okay, it is usually in the anti-clockwise direction the sigmoid volvulus is going to happen. So please remember the direction will be anti-clockwise. It is going to happen in an anti-clockwise direction, the sigmoid volvulus or the twisting of the organ. Now what are the risk factors? Why there will be twisting of the organ? Why there is going to be twisting of an organ? So there are two important reasons for it, or two important risk factors for it. First important is, I hope all of you are quite aware, for example, this is your intestine. This is your bowel. Okay? And one of the borders of your bowel, the inner borders of your bowel is definitely going to have a fatty tissue which is attached to it. Okay, it has two reasons. First, it is going to hold the bowel. Second, it is actually going to give blood supply to the bowel. And what is this tissue called as? This tissue which brings blood vessels to the bowel, it is known as the mesentery. This tissue which actually brings blood vessels to the bowel is known as the mesentery. Important, it does not only give blood supply to the bowel, but it also holds the bowel in place. Important is, if a patient is having a narrow mesentery, if the patient is having a very narrow mesentery, इसमें बहुत छोटी सी पतली सी mesentery है बस. Okay, this patient is having a very narrow mesentery. Can you see now his intestine or now his sigmoid colon is free? आराम से घूम सकती है इधर उधर. Now the sigmoid colon is very, very free. So now this sigmoid colon, as it is free, it can immediately undergo malrotation. It can immediately undergo twisting. Okay, so as there is a very long and a narrow mesentery, therefore the sigmoid colon is free and therefore it can undergo twisting. Okay, that is one of the reasons. Second, if the sigmoid colon is loaded, अगर sigmoid colon में बहुत ज़्यादा feces भरे हुए हैं, for example, if the sigmoid colon is full of feces, it is very loaded. Definitely due to the weight also, it can undergo malrotation. Due to the excessive weight inside the sigmoid colon also, it can undergo malrotation. That has to be understood. Okay? So these are the important risk factors for your sigmoid volvulus bache. One definitely is a long and a narrow mesentery. That is a very important risk factor that you have to be aware of. Long and a narrow mesentery. And second definitely is a loaded sigmoid colon. It is a loaded sigmoid colon. Now, what is the complaint of the patient? Definitely when the sigmoid colon is undergoing volvulus, if it undergoes twisting, okay, as one of the intestinal part has undergone a twisting, okay, definitely this is a case of intestinal obstruction. So the same features of intestinal obstruction are going to appear over here as well. Okay, will the patient be able to pass the gas? No, the patient will not be able to pass the gas. As the patient will not be able to pass the gas, bache, definitely the patient is going to have marked abdominal distension. Okay, the patient is going to have a lot of marked abdominal distension. All that gas will keep on collecting. The patient will have bloating, flatulence, and there will be abdominal distension. पूरा पेट फूला फूला लगेगा बच्चे का. ठीक है, that is the problem. Next important, you have to remember, the patient can also have obstipation. What is obstipation? I've already told you. Obstipation is inability to pass the flatus. Patient gas या flatus भी नहीं pass कर पाता. That is absolute constipation. Patient will also have, if obstipation is there, definitely the patient is having constipation. The patient is also having a lot of pain in the abdomen because there is twisting of organ ना भाई. अगर organ twist हो गया तो obviously there will be a lot of pain. Yes. So definitely that is the reason why the patient has pain, first thing. Second, definitely as the organ has twisted, there is intestinal obstruction, and to overcome that the intestine will try to perform hyperperistalsis. ज़्यादा peristalsis करने की कोशिश करेगी intestine to overcome that obstruction. Due to that, there will be a colicky abdominal pain in the patient. Next important, the patient is going to have vomiting as the intestine is obstructed. Though it is a late feature, but yeah, vomiting can appear in the patient as well. And lastly, the patient can have strangulation also. Strangulation, why? Strangulation, I've told you, it is decreased blood supply to the intestine. Why? Because now here the sigmoid colon has twisted itself, and that is the reason there will be a part which will not be receiving any kind of blood supply, and as this part is not receiving any kind of blood supply, there will be strangulation, and it can even lead to necrosis of that particular part as well, right? That's the important thing. Now if I talk about the investigations in this patient, definitely the initial investigation, just like any case of intestinal obstruction. अब patient ये बोल के तो नहीं आएगा emergency में कि डॉक्टर साहब मुझे sigmoid volvulus हुआ है, right? So definitely the patient will come with the same complaints as intestinal obstruction. So patient is brought to the emergency, same complaints as intestinal obstruction. So our first line investigation is always the same. It is X-ray abdomen. So we are going to send our patient for an X-ray abdomen. And when we send our patient for an X-ray abdomen, okay, we are able to get a classical feature. Okay, normally X-ray abdomen पे क्या दिखता है? Multiple air fluid levels will be seen, and then we will suspect the intestinal obstruction. But here on an X-ray abdomen, a classical feature is seen. We are able to see two dilated or two distended bowel loops, and these bowel loops which are there, these are distended ones, and they are giving us a classical appearance. क्या appearance दे रहे हैं? Due to twisting of the sigmoid colon, they are giving us a classical appearance. This is classically known as the coffee bean sign. लग रहा है ना coffee bean की तरह? Therefore, this is classically known as the coffee bean sign. Okay, so the plain X-ray abdomen बच्चे will give us a classical coffee bean sign or coffee bean appearance, which is a suspicion. Okay, it is a classical suspicion of sigmoid volvulus. Okay, it is a suspicion for sigmoid volvulus. Next, after this, definitely the patient we can send the patient for a barium enema. And when we do a barium enema in this patient, definitely what we are able to get. Now, definitely we are injecting contrast from his anal canal, okay, or inside his rectum. Definitely that contrast is traveling. It will travel via the rectum. It will travel via some part of the sigmoid. But now where there is a twisting or where there is an obstruction, the contrast will not be able to travel further, right? And therefore we are able to get this classical sign over here. Can you see? This classical sign is seen, called as the bird beak appearance. Yes. So you have to remember, bird beak appearance is also seen in a case of sigmoid volvulus. Important is, bird beak appearance on a barium swallow is a feature of achalasia cardia, but bird beak appearance on a barium enema is a classical feature of sigmoid volvulus. Okay? This is the classical bird beak appearance, but we can name this as multiple things. That means this can also be called as the bird beak appearance. We can even call it as the bird of prey sign. ऐसा लग रहा है ना किसी bird के मुंह में उसका निवाला हो. This is called as the bird of prey sign. It is also known as बच्चे, it is also known as the ace of spade sign. ठीक है? So this is called as the bird beak appearance. It is also known as the bird of prey sign, or we can even call it as the ace of spade sign. We can even call it as the ace of spade sign. These are another another names of the alternative terms which can be used for the bird beak appearance on a X-ray abdomen. Okay, these can be used for X-ray abdomen. This can be used for the bird beak appearance in a case of barium enema in a patient of sigmoid volvulus. ठीक है, उसके लिए ये दूसरे नाम है. No issues with this, anybody? So I'm not writing it again over here. It is just the bird beak appearance. ठीक है, so that will be seen in the patient. Next important is, now what is the investigation of choice? X-ray can be done, barium enema can be done, but both of them are not the investigation of choice. The investigation of choice, we always know, it is nothing else but the CECT abdomen. For a child, we can prefer using ultrasound. That can also show us about the twisting, but the better one is always a CECT abdomen. So if I talk about the CECT abdomen, it will tell us about the twisting as well as it will tell us about the blood supply to the specific part of the intestine. Okay, whether it is having enough blood supply or not having enough blood supply. Now if I talk about the management of the patient, how we are going to manage this patient. So we have to see whether the patient is stable or unstable. Here I am not talking about hemodynamic stability. यहाँ पे we are not talking about the hemodynamic stability. Here we are talking whether the patient is in extreme pain or the patient is having any kind of perforation, strangulation, sepsis. That kind of instability I'm talking about. Okay, so by unstable I mean over here, if the patient is having any risk of perforation, if the patient is having any kind of strangulation, or the patient will be in extreme pain, or the patient is having features of sepsis. That is what is meant by unstable patient. ठीक है, perforation की वजह से definitely the patient is going to develop peritonitis. So if the patient is having features of peritonitis, okay, that is what is called as an unstable patient in a case of intestinal pathology. ठीक है. Now if I talk about the management of a stable and an unstable patient. So if a patient who is stable who comes to me, stable matlab there is no risk of perforation, no risk of strangulation, no features of sepsis in the patient. Okay, so in that condition, definitely first of all I'll go for an emergency management. What is my emergency management in this patient? I will try to actually decompress. Okay, I'll insert a catheter in the patient and then I'll try to decompress all the gas which has been collected over there na, all that gas I'll try to aspirate, पूरा का पूरा gas बाहर निकालूंगा, so that definitely this intestines which have mal rotated, okay, there is a volvulus which is seen, okay, as the gas will be removed they will get collapsed, okay, वो ढीले पड़ जाएंगे ये intestinal loops, and as they get collapsed बच्चे, they are going to come back into their original position. What is this called as? As I'm inserting a catheter via the anal canal into a sigmoid colon and I'm aspirating all the gas which is collected. Okay, I'm decompressing the sigmoid colon. Therefore, this is what is classically called as the sigmoidoscopic decompression. ठीक है, इसको मैं क्या बोलूंगा? Emergency में in a stable patient, I will go for a sigmoidoscopic decompression. I have to go for a sigmoidoscopic decompression. No issues with this, anybody? Sigmoidoscopic decompression should be done in the patient. Got it? Now if I talk about definitive surgery, because sigmoidoscopic decompression जो होता है बच्चे, that will only remove all the gas or air from the intestine, and that will relieve the volvulus for that particular time. But if we do not treat the patient definitively, again the patient will come to you with next episode of volvulus the next time, and there will be high risk of perforation or strangulation the next time. That is the reason why after emergency management, once the patient is stabilized thoda, then you have to take up the patient for a definitive surgery also, and that definitive surgery over here is known as sigmoidectomy. Yes, that definitive surgery over here is known as sigmoidectomy. And you will be like, so why sigmoidectomy करेंगे हम? Okay, so please remember we can also go for sigmoidopexy. What is sigmoidopexy? Definitely fixation of the sigmoid. Okay, I will actually fix the sigmoid properly with the mesentery so that there are less chances of sigmoid volvulus. But if I compare both, we have seen results of both of them, sigmoidectomy and sigmoidopexy. The better results were always seen with sigmoidectomy. Okay, the patient's condition is always better with sigmoidectomy, because with sigmoidopexy, the patient is having higher chances of intestinal obstruction, or if it is not done properly, the patient is having higher chances of recurrence. वापस से sigmoid volvulus होगा. इसीलिए अगर दोनों options में से choose करना है बच्चे, you have to mark it as sigmoidectomy will be a better option. ठीक है? That is the reason. Next, if I talk about an unstable patient. Unstable patient, that means the patient is having perforation, peritonitis, sepsis or strangulation. So these unstable patient mein, I have to go for what? See, now if there is perforation, that means all the intestinal content has gone down into his peritoneum and there is a peritonitis now. Peritonitis will present to us with nausea, vomiting, severe abdominal pain, diffuse tenderness all over the abdomen, guarding, rigidity, cardboard-like rigidity. All of these features were there, right? And maybe the patient can be in shock as well. So in this patient, definitely we have to go for the emergency and definitive management together itself. क्या करेंगे इस patient में अभी? So usually, as there is a risk of peritonitis, you have to definitely open up the abdomen of this patient. So as you open up the abdomen of this patient, you have to go for an exploratory laparotomy. Okay, you go for exploratory laparotomy first. Then, as there is peritonitis, you have to clean the peritoneum. That is, peritoneal lavage should be done. And once you do the peritoneal lavage, you are going to correct the sigmoid volvulus. After you correct the sigmoid volvulus, now what you are going to do is you have to remove the sigmoid as it is perforated. Na? So resection and anastomosis should be done. So definitely we have to remove the sigmoid which has been perforated. Now, as we have removed the sigmoid, okay, this is the descending colon, for example. This is the descending colon and this sigmoid has been removed. Okay, I have removed the sigmoid. Now definitely I can go for a direct anastomosis. I can bring down this is my descending colon over here. Okay, I can bring down this descending colon and I can perform an anastomosis with whom? I can perform an anastomosis with the rectum. Problem is this anastomosis which is there now, it will be too stretched out. Okay, so this anastomosis in most of the patients have shown a chance of or a risk of anastomotic leak. Okay, that is the problem with this. So that is not commonly preferred. Then what we are going to do? We are going to repair or we are going to perform anastomosis later on. But abhi ke liye, if we go for anastomosis, first important, as there is a lot of infection out there, definitely, okay, as there is a lot of infection out there, the sutures which are there, the sutures are not going to stay over there. The sutures are going to come off and there will be high chances of anastomotic leakage, again an episode of peritonitis that we don't want for sure. So therefore, in this patient, we at this point of time, we don't go for directly anastomosis. Is patient mein thode time ke liye what we do, we actually try to bring out this descending colon. We try to bring out this descending colon, okay, on his abdominal wall. Can you see? We are creating actually an opening for this colon on the abdominal wall. Okay, this is a temporary procedure for some time. Why? Because if we leave the descending colon inside only, how the patient is going to pass the feces? Because there is no connection between descending colon and the rectum. That is the reason why here you have to bring out the descending colon, okay, until and unless we repair the anastomosis. So here, as the colon is brought out on the abdominal wall, okay, as you have created a new opening for the colon, this is called as colostomy. This is what is called as a colostomy. As you are bringing out the end and you are bringing out the end of the descending colon and you are performing a colostomy, this is called as an end colostomy. But is it temporary or permanent? It is a temporary procedure. Okay, it is a temporary procedure. After the patient's infection is going to subside, after the patient is going to become stable, then definitely we are going to repair the we are going to definitely perform anastomosis in the patient. Okay, so this classical procedure बच्चे is known as the Hartmann's procedure. इस procedure को क्या बोला जाता है? This classical procedure is known as the Hartmann's procedure. So now what we do in the Hartmann's procedure, let's see. In Hartmann's procedure you have to remember बच्चों, in the Hartmann's procedure what are we going to do? So Hartmann's procedure में याद रखना, this is important because you will also discuss about this surgery in diverticulosis. Okay, in this Hartmann's procedure definitely the patient should undergo what? Should undergo an exploratory laparotomy. Exploratory lap करना है. Plus definitely there should be a peritoneal lavage which should be done. Peritoneal lavage should be done. Plus definitely apart from the peritoneal lavage, definitely there should be a temporary colostomy which should be done. Okay, there should be an end colostomy which should be done. And that is a classical feature. All of these features together, all of these conditions together are done in a case of Hartmann's procedure. Okay, all of these procedures together are done in a case of Hartmann's surgery or Hartmann's procedure. No issues with this, anybody? That is important to be remembered for your unstable patient of sigmoid volvulus. कोई दिक्कत नहीं है इसमें. Hopefully this is fine. ठीक है? If we bring out the colon and create opening for the colon on the anterior abdominal wall, that is a colostomy. If we, in the same manner, if we bring out the ileum, that will be called as an ileostomy. Okay, that is important. Now if I talk about intussusception, if I talk about intussusception in the patient, so if I talk about intussusception now, what is intussusception? It is invagination of one part of the intestine into another, or telescoping of one part of the intestine into another. What do I mean by this? Actually, see, एक part intestine का दूसरे part में घुस जाता है. Okay, one part of the intestine is actually going into the another part of the intestine. This is what is called as an intussusception. This is what is called as an intussusception. Okay, so please remember, here you have to remember बच्चों. Okay, intussusception is nothing but telescoping or invagination of one part of the bowel or one part of the intestine into adjacent. साथ वाले part में घुस जाता है. Okay. So now for example, this is your one part of the bowel. Can you see? It has invaginated into another part of the bowel. This is what is the case of intussusception. This is what is the case of intussusception. Important is this invaginating loop जो होता है ना, the loop which is going inside, the invaginating loop is what is called as intussusceptum. This invaginating loop which is there, it is known as intussusceptum. This invaginating loop which is there, it is known as intussusceptum. It is known as intussusceptum. Whereas this receiving loop which is there, it is known as intussuscipiens. This receiving loop which is there, it is known as intussuscipiens. Important is, ये वाला जो हिस्सा है, this part over here, this is what is called as the, this part over here which is there, it is known as the apex of the intussusception. This is what is known as the apex of the intussusceptum, whereas this part over here which is there बच्चों, it is known as the neck. This part over here is known as the neck. That has to be remembered. Okay, that part is the apex and then there's the neck. अगर वो पूछते हैं बच्चे कि highest chance of necrosis or highest chance of strangulation will be seen in which part of the interseptum, okay, it will be seen in which part of the interseptum, what will be your answer? Whether it will be the apex or whether it will be your neck. Apex and neck, highest chance will be seen of necrosis, highest chance of necrosis will be seen in the neck. ठीक है, high chances of necrosis or high chances of strangulation, rather to be specific, high chances of strangulation will be seen in the neck. Yeah, apex को तो मिल रहा है ना बच्चे, apex को तो यहाँ से blood supply मिल रहा है. The problem is that the neck is getting compressed in between ना, neck is getting compressed in between, that is the problem. ठीक है, so neck पे ज़्यादा chances होंगे usually of strangulation or decreased blood supply. Neck is going to have highest chances of strangulation. ठीक है, no issues with this anybody? That has to be remembered. Now if I talk about the types of intussusception, there are actually two types of intussusception. One is called as a primary intussusception, the other one is called as a secondary intussusception. First is primary and second is secondary intussusception. Now what is the basic difference? Primary intussusception is more common in children, that too very small children. Primary intussusception is common in children, that too very small children between 6 months till 2 years of age. Why? Because the children between 6 months till 6 months they are exclusively breastfed, मतलब उनको breastfeeding के अलावा कुछ नहीं कराया जाता. But after 6 months, I hope all of you are quite aware, they are also given what? Complementary feeds. They are also given another feeding, and that is the reason the peristalsis becomes stronger in this patient. As it becomes stronger, there are higher chances of intussusception in the child. Or after this time, definitely after 6 months, when the child is giving complementary feeds, there are higher chances that the child can even develop diarrhea. Due to diarrhea, there will be a lot of gastric motility, there will be a lot of gastrointestinal motility or a lot of peristalsis. That can also lead to this intussusception in the patient. Okay? Chances of diarrhea will be there. So usually less than 2 years of age. But secondary intussusception which is there, secondary intussusception can develop in adults or another children. Okay? थोड़े से बड़े बच्चे होते हैं ना, usually in school going age वगैरह. So in adults or children, we can have the secondary intussusception. Now important is definitely if I talk about the most common cause. The most common cause of primary intussusception is nothing but hypertrophy of Peyer's patches. Now what is this hypertrophy of Peyer's patches? First of all, what are Peyer's patches बच्चे? Peyer's patches are nothing but lymphoid tissue in the ileum. हर एक organ का अपना lymphoid tissue होता है ना, वैसे ही ileum का जो lymphoid tissue होता है उसको बोला जाता है Peyer's patches. So if there is hypertrophy of these Peyer's patches, definitely that is what is the most common cause of primary intussusception. Whereas the secondary intussusception which is there, it can be due to a lot of polyps or it can be due to tumors. There might be some polyps or there can be tumors which is going to cause abnormal peristalsis leading to intussusception in the patient. Okay? If I talk about the most common site, see what will be the most common site? It will be easy now. If one side, one part of the bowel is large and the other part of the bowel is small, then chances of intussusception are more. That is which side? Definitely when the large bowel communicates with the small bowel. The first part, that is the ileum and the cecum. So the iliocecal junction. So you have to remember the most common site which is there for intussusception or for primary intussusception to be specific will be your iliocecal or the iliocolic junction. तो मैं इसको iliocolic बोलो या iliocecal बोलो, that's one and the same thing. Okay, so it is the iliocecal junction which is the most common site of primary intussusception. But for secondary intussusception, you have to be aware the most common site will be colocolic. That means one part of the colon going inside the another part of the colon. Okay, one part of the colon going inside the another part of the colon. Okay, so that is important. Okay, so primary and secondary intussusception, what is the basic difference? Primary intussusception is usually common between 6 months to 2 years of age. Okay, it is more common in infants or children, whereas secondary can occur in children, can occur in adults. Most common cause of primary intussusception is nothing but hypertrophy of the Peyer's patches in the ileum. Due to that, the most common site of primary intussusception is going to be iliocolic or the iliocecal. Okay. Apart from that, please remember the most common site for a secondary intussusception usually in an adult is going to be colocolic. It is going to be colocolic. Now, what will happen in the patient, bache? What is going to happen in the patient? What will be the clinical features of the patient? So you have to remember the clinical features in the patient will be, first of all, the patient is going to have abdominal distension because see, intussusception jab hoga, so definitely there will be intestinal obstruction na. So all of these what we are studying, sigmoid volvulus हो गया, Hirschsprung's हो गया, Meckel's even, or even a case of intersuspension. All of these are causes of intestinal obstruction itself. All of them are going to cause intestinal obstruction in some or the other manner. ठीक है? So here definitely the patient is going to have intestinal obstruction, due to which again the patient will not be able to pass the gas from the intestine. All that gas will keep on collecting inside the intestine, and that leads to abdominal distension in the patient. Apart from that, as there is more peristalsis, there is a stronger peristalsis that causes abdominal pain in the patient. Along with that, there will be vomiting in the patient as well. Okay. Here there will be a characteristic feature in the child, and that is a classical red currant jelly stools. As you can see in this picture over here, can you see these kind of stools? These stools contain a lot of blood as well as mucus inside them. Therefore, these classically are known as the red currant jelly stools. Okay. Apart from that, over here, if I talk about this, here this is the ileum and this is the cecum बच्चे. This is the ileum and the cecum. Okay. Now this was the iliocecal junction. क्या हुआ यहाँ पे? Definitely at this iliocecal junction, the ileum has gone inside the cecum. The ileum has gone inside the cecum. So can you see? Definitely the iliocecal junction has been pulled upwards. The iliocecal junction has been pulled upwards. तो यहाँ पे जो iliocecal junction होता है, यहाँ पे intersusception होने की वजह से the iliocecal junction has been pulled upwards, and therefore the right iliac fossa. I hope all of you are quite aware. This is called as the right iliac fossa. So this right iliac fossa, if I try to palpate it, it will appear empty. पूरा का पूरा right iliac fossa क्या होगा? Empty होगा बच्चे. ठीक है? So here there will be an empty right iliac fossa, that is classically called as the dance sign. That is called as the sign of dance or the dance sign. Whereas, can you see over here in the epigastrium? In the epigastrium, due to the intersusception, as one part of the intestine is going into the another part of the intestine, and it is pulled upwards. Therefore, over here in this part over here, there will be a classical feature. क्या दिखेगा? There will be a classical sausage-shaped lump. In CHPS, due to the hypertrophied pylorus, we were able to feel what? We were able to feel actually a olive-shaped lump. ऐसा. But now here definitely the patient will be having which kind of appearance? The patient will be having a classical sausage-shaped lump. ठीक है? The patient will be having a classical sausage-shaped lump over here. ठीक है? अगर तुम feel करोगे लंबा सा एक lump feel होगा, that is a sausage-like lump. ठीक है? So this is a keyword for your examination. याद रखना ये keyword होता है. Olive shaped lump, CHPS, sausage shaped lump, intersusception. That is an important keyword. So apart from this red currant jelly stools, which contain a lot of blood as well as a lot of mucus inside it. It contains a lot of blood and mucus inside it. Apart from that, on examination there will be two classical findings which will be seen. As I've told you, first of all, the patient will have a sausage shaped lump. First of all, the patient is going to have a sausage-shaped lump in the epigastrium. That is a classical finding. And second important feature that you have to be aware of, the patient is going to have, okay, the patient is going to have a sign of dance. Now, what is the sign of dance? Sign of dance is nothing but on palpation, there will be an empty right iliac fossa. There will be an empty right iliac fossa. There will be an empty right iliac fossa. Okay? So that is important. Next important बच्चे, what should be the initial investigation? So initial investigation in this patient can be definitely a X-ray abdomen. On X-ray abdomen, definitely we can see some features like, okay, we can see some features like intestinal obstruction, air fluid levels might be seen. But apart from X-ray abdomen, then we can even go for X-ray abdomen के बाद we can even go for a barium enema. Yeah, we can even go for a barium enema. And on the barium enema, a very classical feature will be seen. On barium enema, a very classical feature will be seen. And what is that classical feature, bachcho? Okay, what is that classical feature? Can you see over here? This is what is the classical feature. Does it appear like a claw? Yes, it appears like a claw. This is what is classically called as a claw sign. When one part of the intestine goes into the another, one of the part which is there, it appears like a claw. Yes, it can also be called as a pincer grasp. Okay, this is what is called as a claw sign. And this part of the intestine, can you see these loops which are there? They are looking like a coiled spring. So this is what is called as a coiled spring sign. So claw sign and a coiled spring sign are the two important features which will be seen on the barium enema of a patient. Okay? So that has to be remembered. The barium enema is going to show us the classical two signs. First is going to be the classical claw sign which will be seen. This is a very commonly repeated image in your exam. ये जो barium वाला है ना, very commonly repeated question of your exam. This is the claw sign and this is the coiled spring sign. ठीक है? That's the important thing. So barium enema is going to show you two important signs. One is the claw sign and second is the coiled spring sign. Second is the coiled spring sign. Very commonly repeated question of the exam, image based question. Please be aware of that. Now next important, the investigation of choice. If they ask you, bache, investigation of choice for child, usually it is an ultrasound abdomen, and as it more commonly occurs in child only, therefore investigation of choice is the ultrasound abdomen. If the ultrasound abdomen does not show anything, then we can even go for a CECT abdomen, but most of the times it is the ultrasound abdomen which works. Most of the time it is the ultrasound abdomen which works. Important is here, definitely there is outer part of the intestine, there is outer intestine which is there, and then we have a inner part which has gone inside it. Can it appear like a target? Yes. जो target होता है shooting का या archery का, definitely, or darting का. So just like that, this appears. Anywhere we see these concentric circles in medicine, always they call it as the target sign, or we can even call it as the donut sign. Donut जैसा दिख रहा है ना? So ultrasound, as you can see, the outer part of the intestine and the inner part of the intestine. This is classically called as the target sign or the donut sign. And laterally इसी part को क्या बोला जाएगा? Laterally this will be called as a pseudo kidney sign. Laterally this will be called as the pseudo kidney sign. No issues with this. And can you see, this is what is intersusception. When one part of intestine में दूसरा part अंदर चला जाता है, this is what is known as intersusception. ठीक है, picture भी आ सकता है. Please be aware. So ultrasound abdomen classically shows us the two important signs. One is known as the target or the donut sign. One is known as the classical target or the donut sign. ठीक है. And the second one important that you have to remember, बच्चे, it is known as the pseudo kidney sign. It is known as the pseudo kidney sign. No issues with this, anybody? That's important. Now if I talk about the management of the patient, what is done for management in this patient? So please remember, management की अगर मैं सबसे पहले बात करूं, here it is very easy. First of all, I'll try to stabilize the patient. वही वाला basic resuscitation, ABC देखेंगे, and I'll try to stabilize the patient by conservative management. Conservative management is nothing. Keep the patient NPO, IV fluids, IV antibiotics, analgesics. 4 things. Then definitely I have to take up the patient for a reduction. Why? Because this cannot be kept like this, right? I have to remove this outside, and as I have to remove this outside, definitely I'm going to go for a reduction. Now, this reduction can be done with the help of contrast enema. Yes, therefore, the barium enema which we do, or the contrast enema that we do, bache, it is considered sometimes as the best investigation or the gold standard investigation also. Why? Because it is not only the investigation which can give us the diagnosis, but it can also be used for treatment. How? Because we are inserting a catheter for injection of that contrast or dye, then we are taking an X-ray. On that barium enema, we are able to see this claw or the coiled spring sign. That has given us the diagnosis. Yes. Then definitely we are going to do what? With the same catheter, we are going to insert a lot of fluid over there. Okay, forcefully हम बहुत ज़्यादा fluid डालेंगे via the catheter of the barium enema. ठीक है? Or we are going to push a lot of air. ठीक है? Either we can push a lot of fluid or we can push a lot of air. Now, as we push a lot of fluid or the air, ठीक है? For example, this is the part which is having intersusception. This is the part which is having intersusception, and this is the rest of the intestine. And as we are pushing a lot of fluid or a lot of air, bache, due to this pressure, definitely this intestine will be coming outwards. Due to a lot of fluid coming from here, this intestine will come out. This intestine is going to come out. Never ever go for pulling it. Never ever go for pulling it. That will cause strangulation or perforation. Never do that. Always push. Always push with the help of either fluid or all with the help of air. Okay? That is going to reduce. Now, if we use fluid for reduction, that is called as a hydrostatic reduction. And if you use air for reduction, that is called as pneumostatic reduction. But both are done with the help of a contrast enema itself. हम एनिमा दे रहे थे, उसी के साथ साथ we have done this procedure. ठीक है? So the treatment which is there, बच्चों, after the initial stabilization, then I have to go for a contrast enema. Contrast enema is both diagnostic as well as therapeutic, as we know. दोनों काम कर देता है वो अपने. And with the help of contrast enema, I can go for what? A hydrostatic or a pneumostatic reduction. A hydrostatic or a pneumostatic reduction. A hydrostatic or a pneumostatic reduction. No issues with this, anybody? Hydrostatic or a pneumostatic reduction. Okay, so that is an important feature that you have to be aware of. Hydrostatic or a pneumostatic reduction has to be done. ठीक है, समझ गए बच्चे? दैट इज इंपॉर्टेंट टू बी रिमेंबर्ड, दिस इज इंपॉर्टेंट। कॉन्ट्रास्ट एनिमा करना है और ऐसी के साथ डेफिनेटली वी कैन गो फॉर हाइड्रो और अ नीमोस्टैटिक रिडक्शन। व्हाट आर द इंडिकेशंस ऑफ सर्जरी? फॉर एग्जांपल, इफ द पेशेंट डज नॉट improve, okay, then we have to go for a surgery. What are the indications of surgery? Here, if the patient is having recurrent intersusception, अगर पेशेंट में बार बार इंटरसेप्शन हो रहा है, दो या दो से ज्यादा बार अगर इंटरसेप्शन हो गया, दैट इज अ केस ऑफ रिकरेंट इंटरसेप्शन। वी कैन नॉट, देयर इज सम प्रॉब्लम, देयरफॉर इट्स बेटर कि जो हिस्से में ज्यादा इंटरसेप्शन हो रहा है, द एरिया व्हिच इज हैविंग अ लॉट ऑफ इंटरसेप्शन, जस्ट कट दैट एरिया एंड डू द एनास्टोमोसिस. We can go for resection and anastomosis, right? So that can be done. Or if there is a perforation or strangulation, I have told you, due to intersusception there will be more peristalsis, and there will be more peristalsis, due to that there will be perforation or there will be a strangulation. So in all these conditions, okay, they are indications of surgery, that is either recurrent intersusception, or it is a case of perforation, or it is a case of strangulation. In all these conditions we have to go for a surgery. And what is that surgery? That surgery is nothing but resection and anastomosis. That surgery is nothing but cut that part which is having recurrent intersusception or the perforation or strangulation and go for a anastomosis. ठीक है, resection and anastomosis should be done. ठीक है, so that is important. Two other causes, rather three other causes of obstruction were remaining. So do we want to continue or do we want to stop? आज कम पढ़ा है वैसे तुमने. Tomorrow won't be a class. Tomorrow I'll be having class somewhere else. So day after tomorrow there will be a class. Okay then. No issues with this. We'll continue day after tomorrow. Okay. So let's meet day after tomorrow. Thank you so much. Good night. Take care. Last line बच्चे, indications of surgery मतलब definitely here if the patient does not improve, like for example if a patient is having recurrent intersusception, बार intersusception is there, or if the patient is having perforation or there is a strangulation, in that condition we are going to do what? We are going to cut the part which was having recurrent intersusception. We are going to cut this part and the remaining part will be joined together. That is what is called as that will be called as resection and anastomosis. That will be called as resection and anastomosis. ठीक है, so that will be done. ठीक है, so that is important. चलो, no issues with this. Thank you so much. So definitely on 16 there will be full day class. After that definitely there will be some points of surgery which will be remaining, because today I thought to complete till intestinal obstruction, but as we are not able to complete that, so still there will be, I hope, one more class, and the other will be half a class most likely will be remaining. Okay, if you thoda pace up, so 1.5 class will be remaining for surgery. Okay.